Hello, everyone, and thank you so much for joining us. Sorry for the few-minute delay. We've had a few technical difficulties. Um, I'm Christina Hawes, the Community Engagement Coordinator for Community Outreach and Engagement Office of Wilmot Cancer Institute. I'd like to welcome you to today's webinar on skin cancer. This webinar is part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CERTEC, and Community Cancer Action Council, or CCAC. This live event has been approved for one AMA PRA Category 1 credit, one CNE credit for nurses, and one contact hour for social workers. If you'd like to receive credit for attending, make sure to fill out our post survey. The link can be found in your confirmation email or your calendar entry. Our presentation today will be followed by a facilitated Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box located at the bottom of your screen. Now let me introduce you to our wonderful speaker. Alicia Mizes, MD, is a native of Rochester, New York, who attended the University of Pittsburgh for medical school, completed her intern year at Memorial Sloan Kettering Cancer Center, and is currently a post-grad year 3 dermatology resident doctor at the University of Rochester. She conducted skin cancer research at the National Cancer Institute and at the University of Pittsburgh, and continues to have an interest in cutaneous oncology and dermatology care for the LGBTQIA+ community. In her free time, she enjoys distance running, aerial acrobatics, and rock climbing, which I have to add is very cool. So welcome, Dr. Mises. We are very excited to have you.
Thank you so much for that introduction. I'm really excited to be here today. I'm just going to start off by sharing my screen to make sure that you can all view my presentation okay. Can everyone view this okay?
That's perfect.
Okay, perfect. So again, I'm Dr. Alicia Mizes. I actually grew up in Rochester, New York, so really excited to be presenting here today. I just wanted to give a shout out to Dr. Blackcloud, who's our program director at the University of Rochester, and who gave me some thoughts about this presentation. I recognize there's a pretty diverse audience out there today, so a mix of community members without a big background in science or medicine, as well as some people who do have a background in science and medicine. So I designed this presentation to both include some more basic information as well as some more detailed information. So hopefully everyone gets something out of it. Are you still viewing my slides okay?
Oh, nope, now you're back to,
Okay.
there you go. That's perfect.
Okay. So just to start off, we're going to have an introduction to the skin. We're going to move from there into skin cancer prevention. We're going to talk about some skin cancer screening recommendations. We'll move on to skin cancer diagnosis and treatment principles. I'm going to review some most common types of skin cancer with some photos, and then just give a summary of the presentation and go over some of the things we talked about today. So just to start off, just to make things a little more interactive, we're going to start with skin cancer, some facts versus fiction. So just for some audience presentation, anyone's welcome to shout out true or false. This is a few statements that are either going to be true or false. So to start off, skin cancer is rare. What are people's thoughts? So false, skin cancer is not that rare. Skin cancer is actually the most common type of cancer. About 1 in 5 Americans will be diagnosed with a basal cell carcinoma over their lifetime, and about 2 million Americans are diagnosed with a basal cell carcinoma each year. So dark-skinned individuals don't get skin cancer. And anyone's welcome to shout out. If not, I'll just kind of move to the true or false after. So this is false. So lighter skinned individuals do more commonly get skin cancer, but anyone can get skin cancer due to sun exposure and other factors. While darker skinned individuals less often get skin cancer, they're often diagnosed at a later stage, since this can involve some less commonly expected areas such as the hands or feet. And darker skinned individuals do have a poorer prognosis due to delayed diagnosis and treatment. So I need sun exposure to get vitamin D. This is false. So you should definitely protect yourself from the sun. Vitamin D is found in a lot of the foods we eat. So vitamin D is found in breakfast cereals. It's found in normal milk, almond milk, other plant milks, found in mushrooms, found in a lot of other things that we normally eat. And you can take vitamin D supplements. So definitely, regardless, you should protect yourself from the sun. So only sun exposure causes skin cancer. This is also false. there are other factors that contribute to skin cancer risk. This includes certain genetic factors, being on immunosuppressive medications increases someone's risk of skin cancer. Besides sun exposure, if someone has a history of other cancers, had something like radiation treatment, this can increase someone's risk of skin cancer. So there are a lot of factors to think about. A base tan is good to start the summer. So hopefully we're all kind of thinking the same thing, that this is false. You definitely want to protect yourself from the sun. When you get a base tan, you're basically having UV exposure that causes your melanocytes, one of your skin cells, to transfer melanin to your other skin cells. So they do this as a photoprotection mechanism, but you are still getting that sun exposure, that UV damage, and those DNA mutations. So you don't need sunscreen in the winter, on a cloudy day, or in the car. So this is false. You do definitely need sunscreen during all those times. So even during the winter or on a cloudy day, you still get the UV exposure from the sun. And when you're in the car, the window glass panes do block a lot of UVB, but a lot of UVA still gets through, which contributes a lot to skin aging and skin cancer risk. So tanning beds don't cause skin cancer. This is false. You get a lot of UVA radiation, 10 to 15 times more UVA radiation from tanning beds, similar levels of UVB. So tanning beds are actually a huge risk factor for skin cancer. So skin cancer prevention, awareness, screening, and education is important. This is definitely true, and this is why I'm here to talk to everybody today. So a few fun skin facts. So skin is the largest organ in the body. The average person has about 300 million skin cells. A single square inch of skin has about 19 million cells and 300 sweat glands. Your skin sheds about 30,000 skin cells each minute, and skin accounts for about 10 to 15% of your body weight. So in a normal person, this could be anywhere from 10 to 25 pounds total, which is kind of wild to think about. That's a lot of skin. We all have roughly the same number of melanocytes. So all people, regardless of skin color, skin tone, do have roughly the same number of melanocytes. They do have differences in the shape, size, and distribution of melanosomes, which are the organelle in these cells that produce melanin that contributes to skin color. So these are a couple fun pictures looking at layers of the skin. So your skin is typically divided into the top layer, which is the epidermis, and the deeper layer, which is the dermis. The epidermis is divided into a few different layers. So the stratum basale is the bottom layer of the skin. Above that, you have the stratum spinosum. Above that, you have the stratum granular layer, and then the stratum corneum. The deeper layer of the dermis is filled with fibroblasts and then a variety of different immune cells, including dendritic cells and macrophages. The dermis also contains hair follicles and apocrine glands and sebaceous glands, as well as nerve fibers and blood vessels. Under this, you have the subcutaneous fat. The epidermis of the skin, as I had mentioned, your skin cells take about 28 days to go through the cycle to get to the top of the skin. The most common cell in the skin are keratinocytes. They're the major population that make up about 80% of the cells in the skin. And then you also in the skin have melanocytes, Langerhans cells, and some other cells. And bear with me, I unfortunately can't look at my notes to myself right now. So we're going to talk a little bit about skin color. So what contributes to skin color? So all people have the same number of melanocytes. Like I had mentioned previously, there are differences in melanin and melanosomes, and the size and distribution of the melanosomes and amount of melanin is what contributes to skin color. With your melanocytes come into contact with the keratinocytes through dendritic processes. Each melanocyte can contact about 40 different keratinocytes. I wanted to mention the Fitzpatrick scale because it's used in dermatology, but mention that there are a lot of kind of controversies with it and limitations, just because it was designed originally focused on more of a Eurocentric population. So the Fitzpatrick scale is a way of grading different colors of the skin, and the main thing it's used for is to predict someone's response to the sun and how likely they are to sunburn. We do use the Fitzpatrick scale, however, when we're treating patients with phototherapy, and it helps us predict what level of phototherapy exposure they need if we're using phototherapy for certain conditions like psoriasis and eczema. So just to have a little fun, I wanted to show people what your skin looks like under a microscope. So what you're looking at here are these pink pictures that are something called a hematoxylin and eosin stain. The hematoxylin stains the nuclei blue, and the eosin stains your cytoplasm and extracellular matrix pink. So we're looking at cuts of skin from, on the far left is the arm, in the middle is the flank, and then on the far right is the back. As you can see a lot of pink and blue, and you see there's other structures I had talked about, like the subcutaneous fat, eccrine ducts, sebaceous glands, and blood vessels and hair follicles. And you can see that there's different thicknesses of the dermis, that pink lower part of the skin, depending on where you take the skin from. So where is your epidermis skin the thinnest? Does anyone want to guess? I'll give a couple seconds. So your epidermis is the thinnest on your eyelids. It's only about 0.05 to 0.5 millimeters thick. Where is your epidermis the thickest? It's the thickest on your palms and your soles. So it's about 0.8 to 1.5 millimeters on your palms and about 0.5 to 4 millimeters on the bottom of your feet. And where is your dermis skin the thickest? So your dermis is the thickest on your back. It can actually be up to a centimeter thick, which is pretty thick. So we talked a little bit about some kind of just introduction to the skin, so you have an idea of what we're thinking about when we talk about skin cancer. Now we're going to move into talking about sun exposure and photoprotection. So what is sun exposure? So this is all related to exposure to ultraviolet light from the sun, and that's the single greatest skin cancer risk factor. So UVA exposure is UVA radiation is divided into UVA1 and UVA2. UVA1 is 340 to 400 nanometers, and UVA2 is 320 to 340 nanometers. So UVA contributes a lot to photoaging, skin cancer, eye damage, develops reactive oxygen species in the skin, and 95% of these UVA rays do reach the Earth's surface and do penetrate into the skin. And you can see in this photo that it does penetrate into the dermis. UVB is 290 to 320 nanometers. This also plays a big role in skin cancer. It's responsible for the sunburn process. It causes a lot of DNA damage. UVB does penetrate kind of through the epidermis and into the upper dermis. And UVB is what we use with phototherapy treatment for skin conditions like eczema and psoriasis. It is important to think about that when we do this treatment, it's called narrowband UVB. That means it's specifically 310 nanometers, so it doesn't carry the same skin cancer risk as when you're getting a lot of sun exposure outside. UVC, it's 100 to 280 nanometers. It does not naturally reach the Earth's surface. It doesn't really play a role in the normal skin cancer risk we think about. UVC is used in certain artificial settings like labs for discontamination or disinfection purposes. So with photoprotection, we think about primary photoprotection first. Primary photoprotection is basically preventing yourself from getting that sun exposure in the first place. So that's going to be your sunscreen and your photoprotective clothing. Secondary photoprotection is mechanisms that your body has, like DNA repair enzymes and antioxidants to fight reactive oxygen species, and basically what's happening after you've already had that sun damage. So we divide our sunscreens into what's called chemical sunscreen or mineral sunscreen. So chemical sunscreens consist of organic carbon-based compounds. These work by absorbing the UV radiation and converting it into heat energy. These chemical sunscreens are absorbed by the skin, so they do carry a risk of causing contact dermatitis, and it takes about 15 to 20 minutes to take effect. So I think that's important to think about when you're putting on your sunscreen. You want to make sure you're putting it on ahead of time, or you're using a mineral sunscreen. So mineral sunscreens contain either titanium dioxide or zinc oxide. They create a physical barrier that blocks and reflects the UV rays. They form a film on the skin, and they're not actually absorbed by the skin. So thus they have a lower risk of contact dermatitis, and they're great for sensitive skin. And they work immediately instead of needing this time to take effect. So I just wanted to cover briefly what SPF is and UV index. So SPF is sun protection factor. That's basically when you look at your sunscreen, it's telling you how much of the UV radiation it blocks, and it's based on a minimal erythema dose, or MED, which is basically saying how much exposure do you need to kind of get the normal response that you would get if you weren't wearing sunscreen. So in terms of the amount that it blocks, we typically recommend people wear SPF 30 at least, SPF 50 if possible. If you wear SPF 15, you're blocking about, you get about a 93% UV protection. So that means your body's getting exposed to about 7% of the UV radiation that you would normally get if you went out and you weren't wearing any sunscreen. If you go up to SPF 30, it's blocking about 95% or so. 95, 96% of that UV radiation. When you go up to SPF 50, you're blocking about 98% of that UV radiation. So once you get beyond SPF 50, you're not really getting much more benefit, but I would just say anything below SPF 30 is, we joke around in dermatology, SPF nothing. You're just not really getting the protection that you should be getting. UV index is what you see if you open your weather app on the phone and you see it telling you what is the UV index outside. It's basically telling you how much time until you're going to burn from the sun exposure and the amount of UV radiation that's outside. So the important thing I just wanted to emphasize is it's never really UV zero. I mean, it's never really a UV index of zero unless it's nighttime. So even if you're going outside, it tells you it's a UV index of 1 or 2, which is pretty low. You should still definitely put on a sunscreen and definitely frequently reapply. So just to go over some specific sun protection recommendations. So as much as possible, you should try to reduce your risk of UV exposure. It's important to sit in the shade when outside whenever you can. You can avoid sun exposure as much as you can between the hours of 10 a.m. and 4 p.m. That's when the sun tends to be the brightest. Sun protective clothing or UPF, the ultraviolet protection factor is similar to the SPF rating for sunscreen. That's going to really help you with reducing your sun exposure risk. We recommend looking for material like polyester, nylon, wool is really great at blocking the sun. You want to look for tightly woven fabrics, stuff that's darker colors. Cotton can be a little bit helpful, but cotton isn't quite as helpful as these other fabrics. And you want to use a wide brimmed hat. A wide brimmed hat is really great at preventing sun exposure on your face. As I just mentioned, you really want that SPF 50 at least. You want a broad spectrum sunscreen, a water resistant sunscreen, and ideally, if you can use a mineral sunscreen, mineral is preferable to chemical sunscreens. But my philosophy is whatever sunscreen you use is a good sunscreen. So you want to use the sunscreen on cloudy days, during the winter time, and in the car because those car windows really don't block enough UV. And we actually in dermatology see a lot of people who get a lot more skin cancer and precancers on the left side of their face just because that's the side that's getting all the sun exposure when you're a driver. I joke around and I tell patients that if we see someone with more skin cancer on the right side of their face, that means they're a passenger princess. So definitely wear sunscreen during all of those times, especially if you're taking long road trips. You should apply it everywhere in the body that's going to get exposure to the sun. You definitely don't want to forget about your feet, forget about your neck, forget about your ears, which are areas that we might not always think of. And you want to reapply sunscreen every 2 hours. You want to do it more frequently if you're outside and you're sweating a lot, or if you are going in the water and that sunscreen is going to be washing off. So I'm just going to take a quick drink of water, then we're going to move more into skin cancer screening. Okay, so now to talk about skin cancer screening. So annual screenings are recommended for adults who are age 35 to 75 with at least one risk factor. So some of these risk factors include a personal history of skin cancer. So that's if someone has a personal history of either a melanoma or non-melanoma skin cancer. This includes if someone is immunocompromised. So we consider organ transplant patients to be immunocompromised or patients with lymphoma or leukemia. People who have organ transplants and are on immunosuppressive medications, it's thought that their risk of squamous cell carcinoma is about 65 to 100 times higher. It's thought that the risk of basal cell is about 10 to 15 times higher, and melanoma is about 2 to 3 times higher. So it's definitely important for these patients to get frequent skin cancer screenings. With lymphoma or leukemia, there's not quite as high increased risk of skin cancer, but it's still important. These patients should also get an annual skin cancer screening. Family history, the big one we think about is melanoma. So if someone has a history of melanoma in first-degree relatives, they should get at least an annual skin cancer screening for the most part. If someone has a history of melanoma in a first-degree relative, typically in one first-degree relative, their risk is about 2 to 3 times higher. It's thought to be about 5 to 7 times higher if they have 2 first-degree relatives with melanoma, and upwards of 10 to 15 times higher if they have at least 3 relatives who have first-degree relatives who have melanoma. Some physical features we think about that could increase someone's risk of skin cancer. This includes lighter skin, if someone has red hair, if they have more than 50 total moles, or if they have at least 2 atypical moles. And then the biggest thing, again, is that UV sun exposure. If someone has a history of blistering or peeling sunburns, this definitely increases the risk of skin cancer, and indoor tanning certainly increases the risk of skin cancer. So the big things again here, sun exposure is really important. I wanted to emphasize with family history, we really think about melanoma. We're not so worried about a family history of basal cell or squamous cell carcinoma. These types of skin cancer are more related to sun exposure, and we're not so worried about if someone's had a family member who's had a basal cell. So moving on to the next slide. So I wanted to go over skin check follow-ups if someone has had a history of skin cancer personally. So if someone has been diagnosed with a melanoma, we typically recommend that they do a monthly self-skin check and that they do a self-lymph node exam as well. For the first 2 years, they should come to see us in dermatology about every 3 to 6 months. And from years 3 to 5, they should come to see us about every 6 to 12 months. After year 5, if they haven't had another melanoma, we typically say you should still come to see us at least once a year and more often if you notice a new spot of concern. For non-melanoma skin cancer history, again, I'm focusing on the most common two, basal cell carcinoma and squamous cell carcinoma. For these patients, we also recommend a monthly skin check that they do on their own. And for the first 2 years, we should see them about every 6 months for a skin check. And if they haven't had a skin cancer after that, then after year 2, we can space out to every 12 months. Melanoma, basal cell, and squamous cell skin cancer are the most common types of skin cancer. So I just wanted to highlight those, but there are a lot of other types of skin cancer where there's variable amounts of time where you may want to see someone for a skin check. So with genetic screening, the big thing I just wanted to emphasize is this is not needed for the general public. So melanoma can carry genetic risk factors. So we do screen in certain situations, but if someone has a history of basal cell or squamous cell skin cancer, unless they have really an exorbitant number, we don't need to do a general screening because it tends to be related to sun exposure. So for people who have a family history of cutaneous melanoma or pancreatic cancer and at least 2 to 3 first-degree relatives on the same side of the family, they should get a genetic screen. If someone has a personal history of at least 3 invasive melanomas, including one at an age of less than 45, then we definitely recommend that these people get genetic screening. If someone has, this gets a little more technical for a second, but if someone has a personal history of a melanocytic BAP1 mutated atypical intradermal tumor or a family history of mesothelioma, meningioma, or uveal, meaning eye melanoma, then these people should also get a genetic screen. If someone has a personal history of 2 or more BAP1 mutated atypical intradermal tumors, then they should also get a genetic screen. I just listed off a few different genes that can be mutated in familial melanoma syndromes. We don't need to, by any means, have anyone memorize this right now. And again, the thing I want to emphasize again is that the general public does not need genetic screening for skin cancer. If you protect yourself from the sun, you are doing everything to set yourself up for success. So how do you do a self-skin check? So I was just here in my clinic today doing a lot of skin checks, but it's important that you check your own skin at least once a month at home since you're going to see your skin every day and more closely when you do these skin checks. Myself and other dermatologists, we only see it when you come in for a skin check. So the American Academy of Dermatology has a lot of great resources, both for providers and for patients and general people in the community. So using a full-length mirror is super helpful to do your self-skin screening. You can examine yourself in the full-length mirror, make sure that you check the front of the body and the back of the body, and that you look at your arms and also your right and left side and armpits with your arms raised. So you want to make sure that you look in an area that you might not normally always be looking at on a daily basis. You want to make sure, like I said, check your underarms, check your forearms, check your palms, check under your nails. You should look at your legs, look in between your toes, and look at the bottoms of your feet. These non-sun exposed areas are less common areas to get skin cancer, but sometimes it can be the bad ones that pop up in these areas. So melanoma can pop up on the bottoms of the feet, on the hands, or under the nails. You can use a hand mirror as a tool to examine your neck and scalp and use that, again, full-length mirror also to make sure you're checking areas that you wouldn't normally see. I think it's a good idea to just mention to if you have a hairdresser to take a look while they're taking care of your hair. We actually see quite a few patients who come in with a skin cancer that was actually first noticed by their hairdresser. So we work closely with hairdressers. You can use a hand mirror again to check your back and buttocks and make sure you're looking at those areas you wouldn't always normally see. I think another important thing is if you live with someone or you have someone close to you who feels comfortable checking your skin, having someone else check your skin about once a month can be really helpful since there are areas that any of us have a hard time seeing on our skin. So when you're checking your skin, what are you looking for? So the biggest thing is just any spots that are really changing. So in dermatology, we talk to patients about this mnemonic we call ABCDE. A stands for asymmetry. So that basically means if one half of your mole or the spot doesn't match the other half. B stands for border. So Any borders that are really irregular, ragged, notched looking, blurred looking, those are things you want to pay close attention to. C is color. So if you have a mole or a spot that isn't evenly colored, if it has shades of brown or black that look abnormal, and if it has shades of red or pink or just a lot of different colors, that's something you want to pay attention to or bring to the attention of your dermatologist or general care provider. D is diameter greater than 6 millimeters or greater than a pencil eraser. I want to emphasize with this one that this one we only worry about more if it's in combination with some of these other findings. So there are lots of benign spots that are greater than a pencil eraser, but the biggest thing is, do you see these other criteria that fulfill the A, B, and C criteria? The biggest one I always emphasize with patients is evolving, which is the E of the A, B, C, D, E. So if you have a mole or a new spot that is rapidly growing, changing, if it's increasing in size, shape, bleeding especially, becoming painful, these are times that you should definitely let your primary care provider know and your dermatologist, and we may want to take a closer look. So now we're going to move into some general diagnostic and treatment principles. I'm just going to take a quick sip of water again. Okay, so to talk a little bit more about skin cancer, so what is skin cancer? So I just want to kind of talk a little bit about general cancer too and try to break it down as much as I can. So I'd mentioned that your skin is always dividing. Normally your skin cells are replaced every 28 days, and this is normal and actually what we want. When we think about any sort of cancer, we think about basically you have cells that are responding to these normal stop and go signals, and something goes out of whack where now they're no longer responding to these normal stop and go signals. So with sun exposure, with some of these other exposures, you get DNA damage and mutations that transform your normal cells to cancer cells. So you can get activating mutations, which are called proto-oncogenes. These are basically genes that are going to drive cell pathways of excessive cell proliferation, which basically means excessive cell division, cell growth, and cell survival. So you basically have all these mutations in the go signal. So your cells are kind of just growing too much, dividing too much, and not listening to any sort of stop signals. You also get these loss of these tumor suppressor genes. So tumor suppressor genes are genes that normally are the stop signal of the growth cycle and telling your cells when it's time to no longer grow and no longer divide. And when you get loss of these genes, you again get this excessive growth pattern and your cells are growing way out of whack, way out of control. So cancer cells have developed these mutations where they're now ignoring normal growth signals and they're proliferating or growing uncontrollably. There's three main types of skin cancer: squamous cell carcinoma, basal cell carcinoma, and melanoma. I'm going to talk about these in more detail later in the presentation and show some photos, but these are the three main types to think about. Another thing to think about with skin cancer and cancer in general is your immune system actually does a good job of preventing cancer from even forming in the first place. So if you get a single cell that's kind of lost its inhibition, it's not listening to those stop signals, it's growing too much, that single cell is often caught by your immune system and your immune system gets rid of it before it can cause any problems. With cancer, cancer has now developed these mechanisms or these ways to prevent the immune system from recognizing it and the immune system for getting rid of it. This is important to think about because when I talk about some treatment, with treatment, we either think about how we can attack the skin cancer itself or how we can actually get your immune system to do the job of fighting off the skin cancer for us. So next slide. So can skin cancer spread? So certain types of skin cancer can spread. I just want to define two terms when we talk about this. So one term we talk about is invasion. What invasion is basically where your cancer is growing deeper into neighboring tissues instead of spreading elsewhere in the body. So you have skin cancer that's growing into all of the normal skin that's surrounding it. Squamous cell carcinoma, basal cell carcinoma, and melanoma all can have invasive growth. They do have this type of growth pattern where they can grow bigger, they can bleed, they can ulcerate, and then even basal cell carcinoma can invade the bone. Metastasis is a term we use to refer to cancer spread to other regions in the body. So metastasis can either be through the blood, which is referred to as hematogenous spread, or lymphatic system, which is spread to the lymph nodes. Cancer can spread to distant organs. So certain types of cancer, most commonly melanoma of these three types, can spread to other organs, including the lungs, including the liver, GI tract, bone, other areas. So that's kind of the more feared outcome we think of cancer, since that typically carries poorer prognoses. So with basal cell carcinoma, the most common type of skin cancer, this only has a metastasis rate of less than 0.5%. So it typically tends to just invade local tissues and not spread elsewhere in the body. Skin squamous cell carcinoma has a 3 to 5% metastasis risk where it could spread elsewhere in the body. What I want to emphasize is that this is for cutaneous or skin squamous cell. This rate does not refer to other types of squamous cell, since people can get squamous cell carcinoma of the GI tract, for example, the esophagus or the larynx or other areas. Melanoma is kind of the main one where we worry about metastasis. It's thought that 15% of patients may develop metastasis during their kind of lifetime after they've had this diagnosis. I do want to emphasize that with melanoma, if we catch it very early, the prognosis tends to be really good. So when we catch melanomas when they're very thin, there is a greater than 96% 5-year survival rate. When we catch melanoma, when it's invaded locally, invaded the lymph nodes, some studies say about a 73% 5-year survival rate. And when we catch melanoma pretty late, where it has unfortunately spread to other areas of the body, it's thought to be a 30 to 40% 5-year survival rate. And here's just a photo where you can see that the 3 different types of skin cancer. And again, these cancer cells can either enter the bloodstream or enter the lymphatics to spread elsewhere in the body. So how is skin cancer diagnosed? So skin cancer is typically diagnosed first by looking at the skin. So when you come to a dermatologist, we first start, just one moment, I'm going to take a quick drink of water. So we first start by just examining your skin with our eyes. There's a lot of lesions where myself or another dermatologist can look even without our dermatoscope and say that looks totally benign. If we have any concern by just initially looking with our eyes, we use this device called a dermatoscope. So this is my dermatoscope right here. And when I turn it on, I can look through a few different settings, and it's basically using a few different types of light, polarized and non-polarized light, so that when I'm looking at the skin, I can look at deeper structures. So I can look at certain pigment patterns, certain structures in the skin, certain colors and skin lesions, and this helps me predict, is this a spot that I'm worried about, or is this a spot that I'm not worried about? Depending on what your dermatologist sees on dermoscopy, they may either choose to monitor a spot, not be worried at all, or they may do what's called a skin biopsy. A skin biopsy involves removing all or part of a lesion to look under the microscope. So the main 3 types of skin biopsies are a shave biopsy, punch biopsy, and excisional biopsy. With a shave biopsy, you can see this in the picture on the left side of the screen in the kind of top 3 pictures. This involves using a thin blade to shave off all or most of a lesion to remove that and look under the microscope. And we typically stop the bleeding of this with either a chemical or with cautery. With a punch biopsy, you're using this cookie cutter looking device to punch a hole in the skin and take out this little circular piece of skin. After taking out that piece of skin, we typically either put in a couple stitches, or sometimes we use this compound called gel foam, which is dissolving foam with hemostatic or basically blood clotting properties. And then we look at that also under the microscope. With an excisional biopsy, this is a more invasive biopsy where you might do this if you want to look at the whole lesion under the microscope. So you're cutting around the lesion, going a little bit deeper. And with this type of biopsy, you do tend to put in stitches. So after you take that piece of skin, it's basically sent up to the lab. It's processed, cut into tissue sections. If you remember that slide that I showed you at the beginning with the pink and the purple, the hematoxylin and eosin stain, that's usually what we first do to try to diagnose the skin cancer. Look at this H&E slide under the microscope. There's a special trained type of doctor called a dermatopathologist. They look at the skin under the microscope and the skin sections, and they look at the H&E section, any additional stains, and then make that diagnosis. Depending on the type of skin cancer, sometimes we order additional testing. This can include gene expression profiling. So sometimes we'll take some of the tissue we removed and send it out for what's called Castle testing, where we look at specific gene mutations. So to go into a few general treatment principles, so I really want to emphasize that a skin biopsy is done for diagnosis. It's not done for treatment. There are so many different types of skin cancer and so many variations within each skin cancer that you really want to know what you're treating first before you just empirically treat something. After we get that diagnosis, one of the common treatments is excisional surgery. So you're basically taking out additional skin with margins around the tissue. Most commonly, this can be done in an outpatient setting in your dermatologist office with just local anesthesia. Someone doesn't always need to go to the OR, but in some cases they do. So I'll go more into some specific treatments later, but there's different margins or different amounts of skin you take out around the lesion depending on the type of skin cancer and the subtype of the skin cancer that it is. If you have a more aggressive type of skin cancer, when you do the surgery to take out the margins, you may right away do a lymph node sampling, which is called a sentinel lymph node biopsy. So basically what you're doing there is you're looking at the lymph node that would be closest to your diagnosed skin cancer, and you're seeing is there any sort of spread of the skin cancer to that lymph node. Depending on the type of skin cancer and if there's any lymphatic spread or spread elsewhere in the body, patients may get systemic therapy, which would involve chemotherapy or immunotherapy or targeted therapy. And then in some cases, you also do radiation therapy. There's a lot of other procedural treatments we do in dermatology that are different than just surgery procedures. So we'll often use topical chemotherapy with either 5-fluorouracil or Efidex or imiquimod or Eldara. Less often we'll use these other topicals like diclofenac or this other microtubule inhibitor. And these tend to have pretty long treatment durations of anywhere from 6 to 10 to 12 weeks. And these are used mostly for very thin superficial skin cancers. We do this procedure called electrodesiccation and curettage a lot, or EDNC in dermatology. So that's used more for smaller, thinner skin cancers. And that involves a few rounds of using a curette to scrape the base of where you did the biopsy, and then electrocautery to basically stop the normal bleeding. And the goal is that you're destroying the lingering skin cancer cells with a little margin around that you didn't necessarily remove during the initial biopsy. Sometimes we'll do intralesional or intratumoral injections like 5-fluorouracil or bleomycin or methotrexate. Not as commonly used now for skin cancer is a procedure called cryosurgery, which is freezing treatment with liquid nitrogen. This tends to be used more for precancers or actinic keratoses. It was used previously for superficial thin skin cancers. If it's, I apologize, one more sip of water. The clinic office that I'm in right now just seems to be really dry today, which is why I'm getting the water. But cryosurgery, if it's used, it tends to be used for a 15 to 30-second freeze cycle with a 1 to 4 minute thaw cycle and done for at least 2 cycles. Some laser treatments are also used, like pulse dye laser, non-ablative ND-YAG, and ablative carbon dioxide laser. And photodynamic therapy is used. It basically involves application of a photosensitizer to the area and then exposure to light that then causes reactive oxygen species damage that kills those precancer cells. We tend to use it more for precancer than skin cancer treatment right now. So I wanted to talk about this specific type of surgery called Mohs surgery. So Mohs surgery is a specific type of skin cancer surgery that's done for skin cancers that are either more aggressive or in areas where we really don't want to remove any extra healthy tissue. So that would include areas like the face, your hands, even the backs of your hands, your feet, your groin, and your shins. So what this involves is the patient comes in and they have this biopsy-proven skin cancer. We mark out a little margin around that skin cancer, take off that initial piece of skin, and then look under the microscope during that office visit. We kind of make what's called a Mohs map, so we can see very specifically where is any lingering skin cancer and where should we go to remove more skin cancer. We can go back to the patient, draw out where we need to take another sample, and then repeat this process again and again until we make sure that we get all of the skin cancer and the patient doesn't have any lingering skin cancer. The first goal of Mohs surgery is to obviously treat the skin cancer first, and the second goal is to have the best reconstruction and cosmetic outcome that you can. Mohs surgery is really great because it helps reduce the risk of scarring. It helps save you as much healthy tissue as possible. And it's really great for more aggressive skin cancers too, where you want to make sure that it's clear with your initial excision instead of doing the additional longer processing that we do for traditional excision. After a patient's entire skin cancer has been removed, in some cases, we let it heal on its own, which is called secondary intention, or we'll do more complex reconstruction like flaps and grafts, or just close it through primary closure. So I was told also to kind of cover if there's any exciting new therapies that are used for skin cancer. There's a few newer therapies that are systemic therapies that have been used over the last 15 years. So I'm going to talk a little bit about those. This is where the talk is just going to get a little more technical for a couple minutes. And I apologize that I'm drinking water so frequently. So With targeted therapy, what we're thinking about is skin cancers that have mutations in a very specific gene, and we want to target that gene. So we either do targeted therapy or sometimes we'll do immunotherapy, which is, I had mentioned before, your cancer cells have found a way to evade your immune system. And now we're basically stimulating the immune system and showing it where the cancer is so that it fights against that cancer again. So with basal cell carcinoma, we will sometimes use systemic therapy for locally advanced or metastatic basal cell. We use these things called systemic hedgehog inhibitors because the most commonly mutated pathway in basal cell carcinoma is the patch-1 pathway. Patch-1 would normally inhibit smooth end, and by an inhibition of this pathway, then you get basically decreases in cell growth, cell survival, and the normal cell regulation you would normally have. When you have inactivation of patch-1, then you get excessive activation of smooth ends, so you no longer have this happen, and then your basal cell carcinoma involves your basal cells excessively growing, surviving, so that you get this basal cell skin cancer. When you have this mutation, you can basically go ahead of the patch-1 step, and you can target the smooth end protein directly, which is what we do with a couple of these hedgehog inhibitors. So vismodegib has been approved since 2012, and sunitinib has been approved since 2015, and these have been shown to have great outcomes with locally advanced and metastatic basal cell carcinoma. With squamous cell carcinoma, we're thinking more of the immunotherapy route. So I had mentioned previously that your cancer cells find a way to evade your immune cells. Your tumor cells express this ligand called programmed death ligand 1 or PDL1, and PDL1 can bind to the programmed death receptor on T cells and basically prevent the T cells from recognizing them and from killing these skin cancer cells. A great way to remember this is that tumors are losers. So the PDL1 ligand is on the tumor, whereas the PD-1 receptor is on your T cell. What we can do is we can use these anti-programmed death receptor inhibitors or anti-PD-1 inhibitors to basically target PD-1 on T cells. So now your T cells are not going to be shut down and they're going to go back to attacking the tumor cell and getting rid of the tumor cells. So there's great outcomes of using anti-PD-1 inhibitors with locally advanced and metastatic squamous cell carcinoma. Cemiplimab has been approved since 2018, and pembrolizumab has been approved since 2020 for locally advanced and metastatic squamous cell. Some of these drugs are also used for other types of skin cancer, in case you're familiar. I mean, other types of other non-skin cancers, in case you're familiar with it from other types of cancer. So with melanoma, we have a lot of different systemic therapy medications that have been used. So melanoma has this mutation called BRAF V600E. That's the most common mutated pathway in melanoma. It leads to excessive activation of this MAP kinase signaling pathway. And this pathway is responsive for excessive cell proliferation, which again, that means excessive cell division, excessive cell survival, and excessive angiogenesis, which is blood vessel growth, since tumors basically need a lot of blood supply and have a lot of excessive blood vessels. So by targeting this pathway, we're very specifically targeting the mutated melanoma cells. So some BRAF inhibitors that are used are vemurafenib, dabrafenib, and ecvorafenib, and MEK inhibitors that are used are trametinib and cometinib. We tend to use actually the BRAF inhibitors and MEK inhibitors together, since by using them together, they're more efficacious and you have decreased risk of side effects. Similar to with squamous cell carcinoma, we often target this PDL1, PD-1 pathway. So we can use the anti-PD-1 drugs, pembrolizumab or nivolumab, and then we can also use the anti-PDL1 drug, atezolizumab. We also target this other antigen, this other marker called CTLA4, cytotoxic T lymphocyte antigen 4, and this is expressed by T cells. This is an inhibitory receptor. So this is another protein that is responsible for quieting down T cells. And by targeting it with ipilimumab, we basically get your T cells excited again to fight off this melanoma. So moving on to just a couple more slides of more technical stuff, then we'll move into some pictures. So there's a new therapy that's been approved for melanoma really over the last year. This is tumor infiltrating lymphocyte, TIL therapy. And this is really exciting. This has been approved by the FDA only since February 2024, so just over a year. So how this works is that the tumor sample is isolated from the patient. The tumor infiltrating lymphocytes or the tumor infiltrating immune cells are isolated from this tumor tissue. They're expanded in culture. So now you have a lot of these TILs. They're sent back to the hospital. The patient gets a short course of the lymphodepleting chemotherapy, since it's basically to decrease some of their other immune cells that are not specific against this cancer. And what's great about these TILs is these TILs that are in the tumor are specifically designed to target the tumor. And we're now just going to make sure a patient has a lot of them. So then you basically give back the patient these expanded TILs, and then you give them several infusions of this interleukin-2, which helps further make sure the patient has more and more of these TILs. And then this fights off against the cancer itself, and it's been shown to have pretty good outcomes for melanoma. So another treatment that's used is T-VEC therapy, which is an oncolytic virus therapy. It's a mutated herpes virus. You're basically having this virus that is specifically designed to enter and target tumor cells and not your healthy normal cells. So this oncolytic virus, it basically enters your tumor cells. It infects these tumor cells. It replicates. It causes tumor cell lysis. And when your tumor cell lyses, it releases these tumor antigens and cytokines. So the virus itself is both basically killing your tumor cells. And then because of the release of these other proteins, your immune system is now going to further recognize the cancer and fight off against the cancer. So you're basically attacking the tumor cells in two different ways. This is often used in combination with other treatments, not always just on its own. And it's been shown to also have pretty good outcomes for melanoma. So we talked about a few different types of systemic treatment that's used to treat skin cancer, some other basics of treating skin cancer. I want to move in now to showing a few specific photos of skin cancer. I just want to give the disclaimer. These photos are taken from Visual DX. They are photos that we use in dermatology for studying these skin cancers, so they are graphic. So if you have a light stomach, just beware. So basal cell carcinoma, it's the most common type of skin cancer. It affects 1 in 5 Americans. Over 2 million Americans are diagnosed each year. It typically presents often as a pearly pink papule that you can see most commonly on the head and neck, but it can have a lot of different appearances. It can appear more as an ulcer. It can appear to be eroded. It can often appear and be bleeding, and it does present in darker skin patients as well. And in darker skin patients like African Americans or Hispanic patients, and more often can be the pigmented type. The biggest risk factor for basal cell carcinoma are a history of blistering sunburns and just kind of overall lifetime sun exposure. It does really metastasize or spread elsewhere in the body. It can bleed, it can ulcerate, it can invade the bone. It can even actually invade up towards the eye. So it is the skin cancer that, even though it grows slowly, a lot of studies say only about 1 millimeter a year, it is really important to catch early and treat this skin cancer. It's typically divided into higher risk and lower risk subtypes. So the lower risk subtypes are superficial or nodular basal cell. These are types that when we treat with surgical excision, we can treat with 4 millimeter margins, or we can often treat these subtypes with the procedure called EDNC that I talked about, or with topical chemotherapy. The higher risk subtypes, there's many other subtypes, but this would include the morphiiform, infiltrative subtype, desmoplastic basal cell. And for these, we would want a 6 millimeter or greater margin. And in some cases, we send patients to Mohs surgery. This tends to be if you have basal cell skin cancer, again, on those very important areas like your face. I talked about the systemic therapy. We'll sometimes in locally advanced basal cell or metastatic basal cell use these hedgehog inhibitors, vismodegib and sunitinib. So squamous cell carcinoma, this is the second most common type of skin cancer. It more often affects men than women. Some risk factors, the biggest is sun exposure. This one is actually more associated with cumulative lifetime exposure, whereas basal cell is more associated with the blistering sunburns. It can also be associated with HIV or AIDS, with HPV, with leukemia, with chemical exposures, and with chronic non-healing wounds. A lot of darker skin patients, 30 to 40% of darker skin patients present with squamous cell carcinoma in a non-healing wound or a chronic ulcer. I had mentioned that there's a 3 to 5% or 4% risk of metastasis to distant areas in the body. With squamous cell carcinoma, we typically also think about higher risk or lower risk subtypes. So with squamous cell carcinoma, it could be what's called in situ, which is actually Latin meaning in place. That means that your squamous cell carcinoma is limited really just to the epidermis. Once it invades deeper into the dermis, we grade it based on whether it's well differentiated, which means that it's slower growing, or whether it's moderately differentiated or poorly differentiated. There are other types of squamous cell, like spindle cell squamous cell, which I won't go into extensively today. but we do think about lower risk or higher risk when we think about the surgical excision and treatment margins. So we tend to do 4 millimeter margins for a well-differentiated squamous cell, whereas we do 6 millimeter or more margins for a moderately differentiated or poorly differentiated squamous cell. Patients will go to Mohs surgery if the squamous cell carcinoma is in certain areas, like I had mentioned, the face, the shin, hands, feet, groin, some of those important areas, or if it's a very high-risk subtype. Topical or interlesional chemotherapy may be used in some cases. Typically, we only do topical chemotherapy or the EDNC if it's squamous cell carcinoma in situ, but there are some cases where we may also do it for other types of squamous cell, and then for locally advanced squamous cell carcinoma or for metastatic squamous cell carcinoma, we can give cemiplimab or pembrolizumab, which again are the anti-PD-1s, which are targeting that immune system pathway. So with melanoma, melanoma is of these three typically the most aggressive type of skin cancer we think about that involves melanocytes. Some risk factors include UV exposure, personal or family history of melanoma, or multiple atypical nevi. With melanoma, there are several different types. So you think about the superficial spreading type, nodular, subtype, lentigo maligna, and acral lentiginous. Those are the four main subtypes. I feel like some people have this conception when we think about melanoma, it's always going to be a dark brown bump. This is not always the case. You can get amelanotic melanoma where it actually has more of a red appearance, and the amelanotic type is more common in kids. And you can get melanoma of the fingers, under the nails. So really important to pay attention to all these areas for melanoma. Melanoma is more likely to be in non-sun exposed areas in patients who have skin of color. So that's why we kind of see these outcomes sometimes that patients with skin of color may get diagnosed with melanoma later and have poor outcomes. So melanoma is one that we don't really tend to treat with topical chemotherapy or just an EDNC or scrape and burn procedure. We recommend excision. The excision margins depend on the thickness of the melanoma. So once we biopsy a melanoma, we're looking for what's called the Breslow depth, and that's looking at how deep the melanoma is going into the skin. So melanoma can be graded as in situ, which similar to squamous cell means that it's basically just limited to the epidermis. And then once it starts going deeper in the skin, we give it that Breslow depth, which helps inform our treatment. Typically for melanomas that are less than 0.8 centimeters, we don't need to do the sentinel lymph node biopsy where we're sampling those lymph nodes. And we do recommend that for melanomas that are greater than a centimeter. Between the 0.8 and 1 centimeter, it tends to be a discussion with a dermatologist and oncologist or oncology surgeon. So with melanoma, we do also think about if there's invasion of the lymph nodes or metastasis to other organs, we may need to do systemic therapy. So that would include your BRAF inhibitor and MEK inhibitor therapy, like dabrafenib and trametinib, your immunotherapy with the anti-PD-1s or PD-L1s, like pembrolizumab or nivolumab, or that TVEC therapy or TIL therapy that I talked about. One more skin cancer, just to briefly mention, is cutaneous T-cell lymphoma. About 75 to 80% of cutaneous T-cell lymphomas are CTCL or cutaneous T-cell lymphoma versus B-cell lymphoma. So typically, this tends to be graded into 4 different stages depending on the amount of the body that it involves. Most CTCL is really just limited to the skin and doesn't involve any spread in the blood. But when you do see a patient where you have concern for CTCL, we tend to do first a skin biopsy. With that skin biopsy, we look for T-cell rearrangement markers, which tell us, are we worried about T-cell lymphoma? And if we are worried based on the skin biopsy, we do look in the blood and do what's called peripheral blood flow cytometry, where we're looking to see, are there any abnormal T-cells in the blood? For limited areas of the body, we may just do topical treatment alone with mid or high potency topical steroids, or some of these other topicals like hermosine and vixaridine. In some cases, we'll do narrowband UVB phototherapy or PUVA. And then sometimes we move to systemic treatments like methotrexate, fixaritine, interferon alpha, and some chemotherapies. I'm not going to talk about these today because I just wanted to recognize there are a lot of skin cancers I can't cover today. Merkel cell carcinoma, dermatofibroma, sarcoma protuberans, microcystic adnexal carcinoma, angiosarcoma, Kaposi sarcoma, sebaceous carcinoma, basically just recognizing there's a ton of different skin cancers. The biggest thing is if you notice any new spot that you're concerned about, you should bring it to the attention of a medical provider. So we're gonna again go over, I know we're kind of short on time, but really quickly, some other skin cancer facts versus fiction, just to review again some stuff from the beginning. So sun exposure is not the only thing that increases your risk of skin cancer. Oh, melanomas do not appear like a dark brown bump. We talked about amelanotic melanoma. If I'm wearing sunscreen, I can stay in the sun as long as I want. This is completely false. You should reapply your sunscreen at least every 2 hours. And regardless, even with sunscreen, you are still getting some UV exposure. So the clouds and car windows block UV, so I don't need sunscreen. This is false. You do still get UV exposure in the winter, even when it's cloudy and through the car windows. Most melanomas come from a pre-existing mole. This is actually false. 80 to 90% of melanomas come from a new spot instead of a pre-existing mole. So any kind of new spot that's rapidly growing, changing, bleeding, that's the biggest thing to look out for. Skin cancer only affects older individuals. This is completely false. It can affect younger people as well. Skin cancer can't spread elsewhere in the body. This is false. We learned today that skin cancer can invade locally, invade deeply into the bone, and can spread to your other organ systems. Sun protections, screening skin checks for appropriate populations and regular self-skin examinations are important. This is true. This is kind of the biggest take home today. So take home points. So skin cancer is the largest organ in the body. Skin cancer, specifically basal cell carcinoma, is the most common type of skin cancer. Sun protection with a broad spectrum sunscreen of at least SPF 50 is the single best way to prevent skin cancer. We talked about, again, you really want to reapply every 2 hours. Make sure you have a mineral-based sunscreen and use sun protective clothing and a wide brimmed hat as much as possible. Treatment options for skin cancer include surgical excision with margins, plus or minus lymph node biopsy, the ED&C procedure, cryotherapy, laser, topical or intralesional therapy, radiation, and systemic therapy. And monthly skin examinations are certainly important for everybody. And I had reviewed that mnemonic, the ABCDE mnemonic, standing for asymmetry, border regularity, color changes, diameter greater than 6 millimeters, and the biggest one being E, evolving. So I know we're short on time now, but I will take any questions or comments or thoughts that people have now. And thank you so much for everyone for coming.
Thank you. That was probably the most informative and best community conversation that I have been a part of. I've learned a ton today, and we do have a lot of questions, but I recognize that we are beyond 1 o'clock right now. So if it's okay, I will send those questions onto Dr. Mizes, and she can answer those, and then I will be able to include them in a follow-up email to everyone that attended today. Is that okay?
Yeah,
Perfect.
I just saw I can see some of the typed questions in. So, I mean, for anyone who wants to hang around for a few extra minutes, and I can hang around right now for some extra time, I can just kind of go through and talk about stuff if that.
Okay. Yes. So before you start that, for anybody that
Yeah,
needs to jump off, that's completely
yeah.
understandable. Please make sure to fill out the post survey. It was sent out. It should be available in your email, your confirmation email, along with the Outlook invitation that you received. It's been recorded, so I will send that out at the beginning of next week, along with any answer to these questions, so that everybody will have access to what we discuss in the coming minutes. If you'd like to stay on, please do. And just as an update for everybody. UR's Department of Dermatology is offering a free skin cancer screening event in celebration of Skin Cancer Awareness Month. So this year they've teamed up with Wilmot COE and Oak Orchard Health for a screening event on Saturday, May 31st, 9 a.m. to 1 p.m. at Oak Orchard's Brockport campus. So I will send out a flyer for that as well. And if
And
our,
I
sorry, go
will
ahead.
actually be there. I was just going to say I will be there volunteering as well too. So if you do come,
Wonderful.
you will meet me in person.
Yes, and if our interpreters need to jump off, understood. But thank you so much for making sure that this is accessible to our deaf community members that were able to participate today. So yes, anyone that needs to go, have a great rest of your week, and we will share answers to these questions if that's okay. All right, so do we want to start? Let's see. Um, can we get vitamin D from the sun if we have sunblock on? And what's the maximum amount of time to be in the sun to get vitamin D?
So I think that's kind of a complex question that I don't necessarily have like a perfect single answer to. So I'd mentioned with the sun protective factor, you still are getting some amount of sun exposure. So even with an SPF of 50, you're still going to absorb 2% of the UV radiation that you normally would. I would say that hold on, the question, I want to make sure I'm answering everything. Sorry, the question went away for a second. So there's no specific maximum amount of time that I can really give for to say like someone's getting enough vitamin D. I would actually say that we now really get more vitamin D from our diet, and that makes the biggest difference. So if I talk to patients about vitamin D, which I often do, I recommend taking oral supplements. There's a lot of great over-the-counter vitamin D supplements out there, and it is actually something we think a lot about in dermatology. So there are a lot of skin conditions, for example, like psoriasis, which can worsen if someone's vitamin D is low. So that is something we routinely measure. And if we see it's low, we tell people to take oral supplements and take pills. Or if it's very low, sometimes we prescribe supplements. The reason I just went into that tangent is because as a dermatologist, I care about people having enough vitamin D because that's important for their skin health. But I would never tell someone you should be getting your vitamin D just from the sun.
Well, and that is a great segue because there was a question later on asking, are there dietary restrictions or recommendations to help reduce your risk of of skin cancer? So it sounds like getting some vitamin D in your diet is a good idea, but are there any other suggestions that you have?
So there's some studies about like certain vitamins that you can get over the counter, like niacinamide or niacin, which we talk about more for someone who has a really high risk of skin cancer. I think the biggest thing in general is really just eating a very diverse diet and making sure that you have all of your vitamins within normal limit. Because stuff that also increases your risk of mutation with sun exposure is if you have defects in your skin barrier and if your skin barrier isn't functioning properly. So there's certain vitamins we always think about that are important for like skin health and hair health. Some of these include vitamin D, iron's important. Um, we see biotin is important, B12 is important, vitamin C is really important. So just in general, if you have deficiencies in vitamins, your skin is just going to be generally less healthy. And if you have a less healthy barrier, you're more likely to get some UV damage from that sun exposure and could subsequently get mutations.
Okay, so it sounds like a balanced diet is the best way to go for improved health in every aspect, including for your skin.
Yeah.
Okay, so on to a sunscreen question. So we had a few of these. So you did say that mineral is better than chemical, but really the best is whatever you wear, as long as
Yeah.
you're wearing something.
Yeah.
But,
Anything is better than nothing.
right. So expiration dates, how do those work on sunscreens? I mean, are those hard and fast expiration dates? Because milk, we all know you can usually have it for a couple of days after the best by date and it's still okay. How does that work with sunscreen?
So I think that's also hard to give a single answer to in that there's a lot of different sunscreens out there. And it depends also like, is it a chemical, is it a mineral, and what specific products they have there. I think that to be honest, you probably would be fine if it's a tiny bit past, but I think just to really make things be effective, I would just make sure you get a sunscreen that is not past its expiration date, because the most likely case would be that the active compounds are just going to be less effective. So it might say it's sun protection factor 50, and it actually is functioning at a lower sun protection factor because the compounds that are in there are just not going to be as effective. So I would just make sure that you have sunscreen that is not expired.
That is probably the best, most comprehensive answer I've ever heard for that question. So thank you for that because I know I always have sunscreen from like last year that's still in there
Yeah.
that the kids didn't get to yet. So I will get rid of that and purchase new. Um, what about skin cancer on your lips? Does that happen and can you prevent it?
Yes. So skin cancer on the lips is actually something we worry a lot about in dermatology, just because that is actually one of the areas that has the highest risk of metastasis. So squamous cell carcinoma on the lips actually does have the highest risk of metastasis to elsewhere in the body. So it is a higher risk area, and that is an area that we would always send to Mohs surgery. Sometimes to think about just taking a step back and going to prevention, you can get chapsticks that have sunscreen in them. So you can actually get chapsticks that actually have SPF 15 or 30. And I use chapstick every day. I use chapstick that has a sun protection factor. And I think that's really important because I'm going to be fully honest, I'm not rubbing a mineral sunscreen onto my lips. That's uncomfortable. But if you get a specific chapstick with sun protection, that can be helpful. Sometimes in dermatology, we do actually see precancers on the lips, or what's called actinic cheilitis, which is basically actinic keratoses, or those precancers on the lips. When we see that, we can treat it with a topical chemotherapy, the Epidex or the 5-fluorouracil, to prevent it from progressing to a skin cancer. So if you do notice unusual persistent scaling on the lips, a lot of the times that really can just be dry lips, but sometimes it can be that precancer damage. And that is something you should see a dermatologist for, that we do manage in dermatology.
Okay. Does having dry skin or skin conditions like eczema and psoriasis increase your risk for skin cancer?
That's a little more complex as well. It really depends on how well it's managed. So there are some certain studies out there and thoughts that if someone has really uncontrolled eczema, especially if they get a chronic wound related to their eczema, that could increase your risk of getting a skin cancer within that wound. And then similar with psoriasis, I think it's something that also we kind of think about our immune system too, and your immune system can be a little bit out of whack with both eczema and psoriasis. So the biggest thing with those conditions is to just really try to control your skin condition well. It doesn't carry the same risk as like when I talked about organ transplant patients. Organ transplant patients have this really significant risk of increased risk of squamous cell, basal cell, and then less so melanoma. But a lot of that is actually related to the medications that are given for transplant patients. So transplant patients, they get medications like oral cyclosporin, oral tacrolimus, and those medications actually are really what increase your risk of the skin cancer development.
Okay. Oh, this is an interesting question. What counts as a first degree relative? You did make a few notions about people that should maybe go in and start their screening, get it done more frequently if they have a number of first degree relatives that have had some sort of skin cancer. So what
Yeah,
does that include?
that would be like your parents, like your grandparents, your siblings. If you're thinking about like, so if someone's third degree, like their like third cousin, like that would not be someone I would worry about with melanoma. If there is concern, I think like one thing we do a lot in dermatology is get a baseline screening on someone. So someone comes in for a screening, we look at their skin, we get an idea of what is their level of sun damage, how many moles do they have, what are their risk factors in terms of family members, and then based on that, we tell them when they need to come back. So sometimes we'll see a patient and we'll say, oh, your skin looks great. You're great about sun protection. We can maybe see you in 2 or 3 years for a skin check. Or sometimes we see someone and we're like, yeah, you've definitely had a lot of sun damage. You may not have a skin cancer we detect today, but we should see you back in a year or even 6 months. So I think the biggest thing is if you have had a good amount of sun exposure, increasing age is a risk factor for skin cancer. So if you're getting up there in age and you haven't seen a dermatologist once yet, getting at least a baseline screening is a good idea.
Great. Um, oh, this is very interesting. If you're traveling, or perhaps if you have lived in a location that's closer to the equator where UV index is normally higher, are you at an increased risk?
So I wouldn't, if you're talking about it in the sense of travel, I wouldn't really worry about that for a short trip. So the biggest risk with sun exposure is really that lifetime sun exposure you're getting over time. So it's really that like blistering sunburns, those repeated sunburns that people are having. If they're going out in the sun every single day and not putting on sunscreen every single day, that makes a bigger difference than if you just have like a fun trip to an area near the equator for 10 days and you're getting some more sun exposure there. Um, I would say regardless, you should definitely be using sunscreen when you travel to areas where you're like near the equator, getting a lot of UV exposure, and then making sure that you carry around sunscreen with you and reapply it. I'm someone where, I mean, I'm a dermatologist, so I'm kind of very focused on sunscreen, but when I travel, I always have my like portable sunscreens that I have in my purse and make sure that I'm reapplying it to my face throughout the day because if you leave your hotel in the morning, you're out all day, like your sunscreen is going to wear off if you're not reapplying. But yeah, a lot of your sun exposure risk is based on sun exposure lifetime long. One thing I do want to emphasize too, though, and sometimes we'll have patients who say, like, oh, now I'm 70, I got all my sun exposure already. It doesn't matter if I start putting sunscreen now. It does, because every bit of UV exposure and that DNA damage that you're getting does make a difference. So even if you haven't been putting on sunscreen now, like now is the perfect time to start.
I found that as I got older, I started using sunscreen much more frequently than when I was a
Yeah,
kid. But there is that opposite where it's why bother now?
but it makes a huge difference. I tell everyone, even if you're 85 and you haven't been using sunscreen, like please start now. Every little bit makes a difference.
And so this one, I don't think that you're going to be able to answer, but maybe you have some common things that you have heard for why do people spend so much time tanning if it's so damaging to you and to your health?
Yeah, I think that is definitely a very complex question that takes into consideration a lot of like biopsychosocial factors. So I think that sometimes people have this belief that having tanner skin is considered more aesthetically or cosmetically enjoyable. And that's why people spend a lot of time tanning. At least that's kind of what I've heard from patients. Um, Tanning is really one of the worst things you can do. It's like tanning is something we say you should never go tanning. You should never go to a tanning booth. And then one thing I want to mention too is sometimes we have patients who are like, oh, my psoriasis gets better when I go tanning because of that UV radiation. But the UV radiation you get from a tanning booth is so many more times and so much more broad than what you get from phototherapy, so many more times stronger and so much more broad than what you get for phototherapy. So if we want to use light treatment to treat a condition like psoriasis or eczema, we really want it to be that specific phototherapy, that specifically 310 nanometers for that very specific amount of time. Because there is always insurance issues, logistical issues, in a few cases, occasionally we'll tell patients like, okay, go get 15 minutes of sun exposure without sunscreen on a particular area of your body that's involved twice a week. But it's really that limited amount. Tanning beds are really like one of the worst things you can do for your skin. Besides just skin cancer, it causes a lot of photoaging. So if you're thinking about doing it for cosmetic reasons, think about how wrinkly and discolored your skin is going to be from all that tanning bed stuff down the line, just so you can get your tiny little bit of tan right now.
Okay. I think that was a very good answer. That's a tough, I mean, I think it depends on the person, right? Why they're
Yeah.
going out and doing this. Okay, so spray sunscreen or lotion?
So again, a lot of it goes back to what is going to be what you can use the best. We do technically recommend sunscreens that are sunscreen creams or sunscreen lotions. They're less likely to cause contact allergy and then just kind of spread everywhere that you're spraying. You don't want to like inhale your sunscreen. Um, but to be fully honest, sometimes like you need to get sunscreen on your back and you live alone. So using the spray sunscreen is better than no sunscreen at all. If this is a question from Joanne, I also see like asking about types of sunscreens, and I think a couple other people are asking about types of sunscreens.
Mhm.
So there's a lot of brands that we recommend in dermatology. CeraVe is a great brand. CeraVe has one of my favorite sunscreen moisturizers that I use every single morning. La Roche-Posay is a great brand too. We really like Cetaphil has some great products. We really like Aveeno in dermatology too. There's a lot of like Tizo is a great brand. There's so many different great sunscreens out there on the market. Again, I think the biggest one is whatever sunscreen you can use is the best sunscreen to use. Mineral-based sunscreens, when possible, are better than the chemical-based sunscreens. And there's a lot of sunscreen brands that do say on it dermatologist tested or dermatologist recommended. So again, some of the brands I mentioned, Neutrogena also is really good. Vanicream is also really great. These are all great sunscreen products to use.
That's good to know because I do have CeraVe. So I'm very glad now that I purchased that, hearing that it's a good brand.
Yeah.
And then the final question that we have right now, and this is kind of difficult. Moles on your head, how bad are they when your hairdresser says get it checked and then dermatology says it's not bad? Should you worry?
At that point, if you've seen a dermatologist for it, especially when they've looked with their dermatoscope, I wouldn't really worry at that point. You can actually get very benign moles on the head. When we think about moles, there's a few different areas that have moles that may look a little bit weirder and be totally normal. So people can have moles on their hands, like on the palms of their hands. People can have moles on their feet, on the bottoms of the feet, and they can get moles even on their lips, in the groin area, and on the scalp. And those are areas that we say are like less typical areas where the moles may look a little weird. There's a few specific names we use for moles on the head, like eclipse nevus, halo nevus, where the mole might just look a little funky, but it's actually a very normal, totally benign mole. So I would say if you have a mole in your head and a dermatologist has checked it, I wouldn't worry about it. That being said, anytime you have a spot that's been there for a while and suddenly it's increasing in size, bleeding, changing, that's the time you should now want to get it rechecked and want your dermatologist to take another look. But having a mole in the head, totally not a bad spot to have a mole necessarily.
Okay. And we're not going to take any more questions because we're already at 20 after, but for the final wrap up, does going to an infrared sauna affect your skin or increase your risk?
I would say it's hard to say based on just like a one time going to the sauna. There is a lot of different type of UV that you can get there too. So just any sort of abnormal like light that you're doing in excess can increase your risk. I'm sorry if I can't give a better answer than that right now.
No, well, I honestly had never heard of an infrared sauna before. So I'm very glad that you knew what it was and were able to answer some sort of insight. But realistically, it comes down to yes, avoid as much of the outside UV as possible
Yeah.
unless specifically told by your doctor, and make sure that you go in and get checks. And for everybody that's available to go to Oak Orchard, you'll actually be able to meet our presenter in person for that free dermatology event. So I will make sure that I put those answers into some text for those that were not able to join us. So thank you for all of the ones that were able to stick it out and stay for an extra 20 minutes. And
Yeah,
thank
thank
you for making sure that you were able to stay and answer some of these live for those that are able to still be here. So we'll see everyone in June for a community conversation on cancer, all focused on cancer survivors. Have a great rest of your week, everyone.
Thank you so much. Thank you everybody for sticking around and I'll see maybe some of you in a little bit.
Yeah. Bye bye.